Hello and welcome to Boomer Banter, the podcast where we have real talk about aging well. My name is Wendy Green and I am your host for Boomer Banter. And with many years of aging well experience and plenty more to come, I am here to tackle all of the uncomfortable, unexpected, and life-affirming questions you've been pondering to help you make the journey a little less rocky and a lot more fun. So if you want to age well, you are in the right place. I read an article in Next Avenue, an online magazine titled Let's Talk About Colorectal Screening After 75. The premise of the article, as articulated by the author Mary White, said, I'm concerned lack of knowledge about the latest screening guidelines, coupled with pervasive ageism, may lead to poor screening decisions for some older adults. Well, that definitely caught my attention, and I reached out to Mary. Mary White is an adjunct professor of environmental health at Emory Rollins School of Public Health in Atlanta, Georgia. She retired from federal service in 2023 after more than 3 decades as a senior epidemiologist focused on disease prevention and cancer control. Mary has a Doctor of Science degree in epidemiology and occupational health from the Harvard School of Public Health. The U.S. Preventive Services Task Force recommends that the decision to be screened for colorectal cancer between ages 76 and 85 should be made on an individual basis. I'm sure we would all be grateful to never have to have another colonoscopy, but what are the individual circumstances we should be aware of? And then my gynecologist told me the last time I visited that I no longer needed to have a pap smear. That's a typical recommendation once a woman reaches 65. But what about women in other risk categories? The U.S. Preventive Services Task Force recommends that all women get screened for breast cancer every other year, starting at age 40 and continuing through age 74 to reduce their risk of dying from this disease. But what is magic about the age of 74? Does breast cancer no longer show up as we get older? We all want to age well and avoid illness for as long as possible. And today, we will gain some knowledge about screenings and caring for our health. So join me in welcoming Dr. Mary White to the Boomer Banter podcast.
Hello. I'm happy to be here. Thank you for the invitation.
Oh, I'm so glad that you were able to join us. And we did have to reschedule this once. So I'm really glad that this worked out, that you're here. So you are a doctor of epidemiology. What does that mean? What does an epidemiologist do?
Right. Well, yes, I got my degree in a school of public health. And epidemiology is considered basic science of public health. The word has the same root as epidemics. I think, sadly, a lot of people became first introduced to epidemiology during the COVID pandemic. I'm not that kind of epidemiologist, actually. My career, I have focused not on infectious diseases and microbes, but instead have focused on environmental exposures, chronic diseases, and things like cancer. And so our tools, when you're looking at chronic diseases, tend to be more data than laboratory samples. So we look at trends over time. We compare one population to the other based on different risk factors, identifying who may be at higher risk, the effectiveness of different interventions to reduce risk, that sort of thing.
I'm so glad you cleared that up because I definitely thought about epidemiologists as like epidemics, COVID and the flu vaccine.
Yeah, well, the label epidemic gets thrown around a lot. I always talk about an epidemic of this, that, or whatever. I think, given the fact that we've all lived through the pandemic, happily, we may see that term used a little bit more thoughtfully. We've all lived through a real right?
So I wanted to ask you about that Next Avenue article about screening for colorectal cancer after 75. None of us enjoy that. Oh, what would be the things that we would need to consider that might encourage us to say, yeah, I guess we still need to be screened after
Well,
70?
honestly, I was so flattered that you reached out to me about this article. It's a topic near and dear to my heart. As I mentioned in the article, my father had colorectal cancer, but at a time when colorectal cancer screening was not recommended, it wasn't even a thing. And so having lived through the experience of his cancer and knowing now that that can be avoided if we are successful in identifying cancers early, or you mentioned colonoscopy, if you find a polyp and remove it, you may actually stop cancers from even occurring. I mean, since those resources and tools are now available, I want people to take advantage of those tools if they're appropriate for them. And in my conversations with friends who are in their early 80s and so forth, I'm struck at how little they know about screening and what their doctors are telling them. So that's what prompted me to write the article. Always happy when someone reads it. So screening, we are talking about finding something before there are symptoms.
Mhm.
So if a person is experiencing symptoms, or if they, for example, find blood in their stool, yes, of course, they should seek medical care, get that worked up, see what's going on. That's not screening. That's medical follow-up, right?
Right.
Screening is basically you're looking for something that the patient doesn't know they have. And colorectal cancer is that kind of a cancer that can occur without people being aware that it's there. So the question is, when you get a little bit older, are the risks of finding it greater than the benefits of finding it? Sometimes better just leave well enough alone, So what should you think about as you're approaching that age where routine screening is not recommended for average risk adults? As you mentioned in your intro, it's not that screening for colorectal cancer is actively not recommended. That's true for people aged 85 and over. It's
Okay.
that middle ground between, as you said, ages 76 to 85, where the official recommendations say those should be individual decisions based on things like how long has it been since you were screened? I mean, if you haven't been screened since you were 60, hey, you might want to get tested, And things like uh, your own personal risk profile. Have you had polyps in the past? Well, then you're not at average risk anymore. Okay, well, these
No.
recommendations are average risk. So if you have some sort of history like that, okay, well, maybe these recommendations don't apply to you, Like maybe
Right.
you really do need to get tested. Things like family history, and your patient preferences. I talked to a number of people who are in their 80s, and there are different perspectives about how aggressive they want to approach some of these screening decisions. And that's a legitimate issue in and of itself.
Sure, because
Uh,
go
yes.
ahead.
Well, the other thing I take for granted, but I shouldn't. Yeah, what a provider often focuses in on is life expectancy, which
Right.
I think is better thought of in terms of your overall health. Are you healthy enough to undergo the screening exam? And if something's found, does it make sense to medically intervene given everything else that's going on with you? Those are the kinds of overall health decisions that also should inform these decisions. Because again, we're talking about finding something early that isn't causing any problems now, right?
Yeah,
So,
and those are tough questions though, because a lot of times you wonder, is it, as you mentioned in the article, is it ageist that the doctor says, well, we probably don't need to screen you anymore. You're 75, you're 80, maybe you got another 10 good years. Or is it really, how do you as the individual know that there's more to this than just, well, we don't need to do this anymore?
well, when it ageist, there are many components of being ageist. And one of them isn't necessarily always that they're being mean or uncaring. Here, it's sort of like you're assuming everyone's the same at whatever that age is. So, as 75-year-old, if you've ever been to a high school reunion, you know that people are very different at whatever the age is.
So
Okay.
true.
So if a provider understandably is considering age as one of the criteria for whether or not a person should be screened, hard to blame them because most of the recommendations are structured around your age. The issue is it should be more than just your age, right? Um, Looking at you, yeah, as an individual patient, and that's where the decision can be individualized.
Right. And that's a big part of what we wanted to talk about today, is that it's not your age that should determine any of these screenings that we're going to talk about. It's you and your history and your health and, your
Well,
preference,
yes.
right?
Well, yes, best probably phrased, not age alone. Because as I
Not
said,
age.
most of the recommendations are structured around age. And if you have to read the yes and, okay. And a lot of us as we age, for one reason or the other, I think you mentioned this too, maybe we're not at average risk. Remember, these recommendations are for people who aren't at higher risk for one reason or the other. And there are a lot of those one reason or the others that need to be thought
Mhm.
about.
Yeah. Anything else we need to say about colorectal
Well,
screenings?
yes, I would also add, you mentioned colonoscopy, and it's not the only test that's approved. So if people are hesitant for a colonoscopy for a lot of legitimate reasons, there's the prep, you have to have someone drive you home, your insurance may not cover screening a colonoscopy, I don't know, whatever, maybe legitimate reasons. There are other options, and one of the ones that is becoming more popular is the Cologuard test that gets advertised on TV, where it's something you do at home and you send it away, so there's no prep involved. So I would definitely encourage people who are hesitant about colonoscopy to at least talk to their doctor about some of these other options for screening purposes. Okay, this is average risk
Right.
people, right? No other high risk screening, no symptoms. But if you go that path, you need to be prepared that if they find something, you're going to need to have a colonoscopy. Okay, so
Because that's where they can then, if they see a polyp, they can remove it and they can do preventative work.
right, but um, the there are quite a few people who aren't screened or aren't up to date with their colorectal cancer screening,
Yeah.
and so the guidance always is the test that works for you is the right test for you, right? So
Right.
yeah, as long as you know, be
Yeah.
prepared. If they find something, you're going to need to have a colonoscopy.
Okay. That's good. Good to know. Thank you.
Okay.
So the next thing I wanted to talk about, Mary, is that when we talked initially, you and I both found out that we are children of mothers that took DES. And a lot of women, for those of you that don't know, a lot of women took DES if they'd had a miscarriage. And this was a drug that was supposed to help prevent a future miscarriage. And then they found out later that daughters of mothers that took DES were at higher risk for cervical cancer, I believe. Is that right,
Yes,
Mary?
right. It's
Cervical
a
cancer.
rare form of cervical and vaginal cancer.
Okay. So, like I said in the opening, my gynecologist said, I don't need any more pap smears. But I'm wondering if this is one of the higher risk things, the fact that I'm a daughter of a mother that took DES, that might say, well, maybe you should still have pap smears.
Yes, it is. Excellent. But the guidance for cervical cancer screening, again, talks about average risk women. And we could touch upon that in a moment. But the footnote clearly says these recommendations do not apply to women who've been exposed in utero to this particular drug, DES. Okay, well, what about them, right? So I said,
What about us, Mary?
yeah, what about them, right? I understand. Right now, there are no formal recommendations for how a woman should be screened. Like the U.S. Preventive Services Task Force, as you've mentioned, doesn't say anything about how those women should be screened, just that their standard recommendations don't apply to them.
Hmm.
This is, I understand, an active area of discussion within the community of gynecologists. And I've been told that there may be a statement coming out fairly soon that offers some more clearer guidance now that so many of these women that are often called DES daughters, yeah, they were exposed like in the 50s, right? 50s,
Right.
60s, right?
But
So
it's a big
yeah, so
population now, the baby boomers.
well, that's right. But for years, they were under age 65. So this issue of you don't need to be screened, well, didn't apply to them. I mean, so they would be screened anyway, right?
Right. Right.
But their doctor may approach it differently, um, take extra s- swabs on the vagina, look at the carefully or whatever. I mean, but at least when they were under age 65, this wasn't the issue that it is today, because now many of that birth cohort are well in their 60s and 70s, right?
Well,
So
that's
what
right.
about them? Yes. So I would say on this one, stay tuned. But I think your gynecologist would be not correct to say that didn't need it. But now, what kind of screening is appropriate for you? Um, I think there's some working guidance my gynecologist follows, that sort of thing. But it would be too simple, I think, just to say you don't need to be screened. All right. Now, there may be a basis for that recommendation, but it would not be the U.S. Preventive Services Task Force because they have not said that.
They have not said that. And I just want to be clear. I mean, as Mary, she's an epidemiologist, a researcher. She's not a medical doctor. And so she's very careful about, giving specific recommendations. But what I'm hearing you say, Mary, is that women who may have been exposed to DES in the uterus might want to go back and talk to their gynecologist and say, well, maybe we want to talk about what might be appropriate.
Yeah, yes, absolutely. The wise guidance is always talk to your healthcare provider. Yes, and major disclaimer. Major disclaimer. I can't give you medical advice. Don't follow my advice.
She's not a medical doctor.
Right.
Okay. Are there other reasons besides DES that a woman over 65 might be at higher risk that might want to consider continuing screenings,
Well,
gynecological screenings?
well, yes. I mean, um, the recommendations for cervical cancer specifically, they're written in a way that actually describe a woman age 65 as being at low risk because she's had negative tests before age 65. So it's more than just age on this one. Women are recommended, this is average risk women. I'm going to pull up this statement. average women, according to the experts, don't need to be screened for cervical cancer after age 65 if they have had an adequate prior screening history and are not otherwise at high risk. So what is the screening history? And it has to do with, let me see if I can get the exact wording.
What is with screening history and what is high risk?
Well, yes, screening may be clinically, I'm reading from the guidance. Screening may be clinically indicated in older women with an inadequate or unknown screening history. Recent data suggests that 1/4 of women aged 45 to 64 may not have been screened for cervical cancer in the preceding 3 years. So if you haven't had a pap test for a long time, that's another reason why, well, you might need to be tested. In particular, like women with limited access to care, women from certain minority groups, women from countries where screening is not available, they are more likely to not have had adequate prior screening. So the idea is that if you've had multiple negative tests up to age 65, it's highly unlikely
that it's going to
you're going to
develop.
benefit from further screening. So
Okay.
it's more than just age. Right. And so the other high risk categories really relate to the woman's medical history. If she's had high grade precancerous lesions in the past, for example, you mentioned DES exposure. The other thing to keep in mind too is if you've had a hysterectomy and you are otherwise not at high risk, your hysterectomy wasn't because of cancer, for example, and your cervix was removed, you don't need to be screened even if you're under 65, okay?
Yeah, that makes sense. That makes sense. I want to move on to the breast cancer. So all three of these screenings, cervical cancer screening, colonoscopies, and breast cancer screenings can be unpleasant and uncomfortable. But the guidelines say after 74, you don't need to be screened for breast cancer anymore.
Well, actually, they don't say that.
Ah,
There's a fair amount of careful wording on this one.
okay.
So now we're talking about the U.S. Preventive Services Task Force recommendations. And what they actually say is they say nothing. They don't say yes, they don't say no, but instead they're they give it an insufficient evidence. So here what they say is they've concluded that the current evidence is insufficient to assess the balance of benefits and harms of screening mammography in women 75 and over. So it's neither pro or against. It's insufficient evidence. That's it.
Gives us
Okay,
no guidance at all.
exactly. Well, I'm sure to say no guidance at all may be too broad a brush.
I'm a podcast host. I can say that.
Well,
You
did
can't.
they have a thoughtful documentation that discusses clinical considerations and this sort of thing?
Right.
Okay, so, but they're not the only game in town. And you and I talked about the American Cancer Society has its own recommendations. Okay, so the American Cancer Society says that you had mentioned already actually their recommendations are different in many different ways. So they recommend, I'm assuming maybe some of your viewers could be in their 50s. If they are, the advice is if you are age 45 to 54, you should get mammograms every year,
Okay.
not every other year. Okay.
All right.
Okay. So, and then the American Cancer Society says that women 55 and older, no upper
top
age limit,
age.
no,
Okay.
okay, should switch to mammograms every 2 years or can continue yearly screening. And then they say screening should continue as long as a woman is in good health and is expected to live 10 more years or longer. There you go. So again, is this issue, like if you felt a lump that's, you need to get that worked up, right?
Right.
So we're talking about people who otherwise have no reason to think anything's wrong, and how long after a certain age should they continue screening?
I
And
know. And I guess in some ways it's an individual choice, right? If you look back and you say, well, I don't have a family history of breast cancer. I haven't had any kind of lumps or anything that has shown up in my previous screenings, and I'm over 70, maybe I can stop. But that's your individual choice. You have to discuss that with your
I talk to your doctor, yeah, because there's not only sometimes you can do more harm than good. You start interventions, that may not work. There might be some other health conditions that really you should be worried about. I mean, whatever. You have to talk to your doctor about that. Yes, we both had mothers who lived into their 90s. I remember shocking my colleagues when I would tell them that my mother, age 80 something, had just gone for her mammogram, and they were like, "What?" but 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 she felt this is how she was taking care of herself. And I remember when one of her doctors told her that she didn't need to be screened any longer, she didn't take it as, "We think you're going to die tomorrow." She took it instead as, "Well, that's a relief."
yes, that's right.
Right.
Which is how I would take it too. If they told me I didn't need to be screened anymore, I was like, oh, good. I don't. So let's switch gears though. Okay.
Okay.
We've been talking about all this screenings and preventative but as you told me when we first met, the focus of this screenings is on finding the disease and then treating the disease, right? So you want to switch the lens to health. So tell me more about that. What you mean by that?
Right. So, yeah, you want to, most of these screenings, with the exception of colonoscopy, where you find polyps and the polyps are removed, arguably is a form of prevention. But mammogram is not going to prevent anything. It benefits only women who already have breast cancer by allowing their doctors to find it earlier, or the treatment could be better. Okay. So what you really want is you don't want to get breast cancer at all if you can avoid it, right?
Right.
That's easier said than done. There are recommendations along those lines. They often focus on personal risk factors, and they may provide guidance saying that alcohol actually is a risk factor for not only breast cancer, but other forms of cancer.
I just
Um,
saw an article about that, like even one glass of alcohol
that's
can
right.
raise your risk.
Well, yes, that's right. Yes, and I was on an advisory committee for a project that was looking at ways to prevent breast cancer, and they had identified 23 different factors that can contribute to breast cancer. I mean, it's a complex disease. Um, the thinking is that many different factors over the course of many years can contribute to the development of any cancer. All right. So most of the advice on how to reduce your risk of breast or any other cancer usually falls along the lines of all those things you already know are good for your health. Be more physically active, eat more fruits and vegetables, um, get good rest, the whole thing. And anything you do along those lines, my sense is, we had the conversation earlier, is a good thing because you don't you you can't blame yourself if you get cancer. It's never a result of something you did or didn't do. Try to you can do what you can. That these risk factors are measured on a population level, not what happens to you individually.
Mhm.
So we all know people who seem to be models of perfect health behavior, and yet, they receive a cancer diagnosis. So it's much more complicated than that. So my sense is, yes, you do these things. Yes, in theory, you're lowering your risk of cancer by some of these things. But there's no downside because treatment outcomes are always better or seemingly um, more likely to be better, maybe not always, more likely to be better if the patient's in otherwise good health at the time of their diagnosis. So there's reasons to just at this point in our lives, give yourself permission to focus on your own health, realizing that it's only it's all benefit, it's all good. There's no guarantee that anything you do at this point in your life is necessarily going to keep you from receiving some kind of cancer diagnosis, unfortunately. The likelihood is at this point that you're more likely than not to get cancer, okay? But if you do, it's not your fault. But
Say that again. You're more likely than not because we've reached this age and we haven't had.
well, yeah, that's right. Because if you look at the probability of developing certain cancers so in the next 10 years for someone in their 60s or 70s, um, it's less than 50%. So that's how, yeah, more likely than not,
Hmm.
not, but anyway, the rates are high enough to be the reason for you to do what you can to lower your risk, be screened, follow up on any problems you may experience quickly, this sort of thing.
Yeah, and I like what you said that even if it doesn't, your lifestyle choices don't prevent you from getting the cancer. If you're in better health, your chances of a recovery and handling the treatments are going to be probably better than
But
if you were.
yeah,
Yeah.
yeah. And it cancer is just one of several conditions one may encounter as they age. So usually the recommendations, I'm struck at how the recommendations for Alzheimer's prevention sound so much like the recommendations for cancer prevention.
Yes, it's about the lifestyle, I think, is what we hear all the time about
Well,
how we eat and movement and
yes, and
socialization and all of
well,
that.
yes, I would say yes, as an epidemiologist who doesn't focus only on an individual patient, but looks at these things population wise.
Mm.
There are a lot of factors in our culture and in our environment that can make it very difficult to always make the healthy choices. And they're
Absolutely.
right. And so there is more that can be done on a policy level to make those healthy choices easier to make, more
Can
affordable, easier to make.
give me an example of what that would look.
Well, like there are people who live in communities that are considered food deserts. They don't have access to affordable fresh food, for example, or places where it's not safe to walk.
Yeah,
You can go down the list, and then we have a culture and marketing that encourages people to consume products that we know are harmful to them. We've
sure.
we've got all kinds of substances that are harmful in our consumer products that are not uh, regulated. You can go on. Right?
Right, right.
Yeah, I'm always quite hesitant about the lifestyle label because that seems to put the onus squarely on the individual and personal responsibility. And as a society, we have responsibility for all of us and our communities to see what collectively we can do to make the world healthier and easier for people to live healthy lives.
So when you're looking at populations, what I think I hear you describing is that the greater risk may be in populations that may be lower income because they have less access to healthy foods and fresh foods, let's say, and um, walking areas, and you just let more stress. I mean, it is
Yes, and more air pollution and
more
other forms of
environment.
environmental contamination, and yeah,
Yeah.
the whole nine
Yeah.
yards.
So you find that when you were doing your research that the population of where you live and the environment you live in has an impact.
Yes, it's not a unique finding. I mean, that's been documented by many people to the point that there's this saying, your zip code is more important than your genetic code. So
Wow.
place matters, absolutely. And if
Mm.
you look at the geographic distribution of these different chronic diseases, yes, it does vary a lot. And
Interesting.
what's driving those geographic variations? It's not individual willpower.
Right. No, it's not. So, and your zip code matters more than your DNA.
hmm
Is that right?
hmm Well, that's one of those quotes. I think it was originally Dr. Jim Marks who said that, but I've heard that stated a lot. Maybe it's well, you're a podcaster, so you can live with oversimplifying things. But yeah, there's a fair amount of truth to that. Yeah, they often say that um, genetic inherited genes represent like a small fraction of most cancers, 10% or something, and then the 90% is something else. Then
Yeah. And I hear that number also with Alzheimer's.
ah,
Yeah. So it's very interesting that we fear these things because we say, "Oh, well, my mother had this or my father had that," and maybe that's really not where the fear should be placed. It should be
well,
placed more.
you don't want
Go
no
ahead.
fear. It's all about hope.
Hope.
Hope. That's right. You want to aim for what you want, health, right? So you want to be cautious and informed, but you don't want to. You can't enjoy life if you're living with fear. I would say you can be hopeful. From your podcast is an example of that. Practicing active hope.
Active hope. I like that. I like that, Mary. Thank you. So, are there federal initiatives that you're aware of to help us address some of these environmental issues or geographic issues or zip code issues?
Well, yes, you'd probably need to invite somebody who still works for the federal government to speak to that point. And I'm sure many of them would welcome the opportunity to talk about what they're doing and would probably welcome some more secure financing funding for those activities.
Yeah,
But it's not just the federal government. There's a lot that happens at the state and local level, and people may want to get involved in their own community to see what's going on there and what they might be able to do to help advocate for some of these positive changes.
I do. I am aware of some local community gardens where
Yeah, that's a perfect example. Yeah.
well, people can grow some of their fresh vegetables, and it's fun because it's social too.
hmm
Yeah. Give me, based on what we've talked about, the screenings and being proactive about the choices we make and understanding that it's not totally up to us about what happens to us, but we do have hope and
Yeah, you have agency. You have
we have,
agent.
there you go. Um, Give me 2 to 3 takeaways that you'd like to leave with the audience today.
Oh, okay. So one takeaway would be take advantage of the screening modalities that are available and make sure with your provider that you're up to date with the various tests and talk to them about any questions you may have about the tests that are appropriate for you given your situation and your age. So that's one. Another one, I would just echo what you were saying. Please don't ever think that if you get a cancer that is in any way a result of a failure on your part, something that you did or didn't do. It's too complicated for you to think that way. Just go forward knowing that there are always advances in treatment options for a number of cancers, and science progresses, or cautiously optimistic about that, but we don't want to put all of our eggs in the treatment basket, which is why prevention is so important. So to the extent that people can get engaged in their community, in civic organizations, and forgive me for saying, you have a voice in the ballot box as well, get involved in that, because prevention is, I think, would be recognized by all the medical authorities. They'd much rather have these illnesses prevented than have to be treated.
Oh, for sure. And it would save a lot of money. So Mary writes for several publications, one being Next Avenue. And I'm going to share all of the links that she gave me to Next Avenue and to the American Cancer Society and to the National Institute of Cancer, right?
Or National
this
Cancer Institute.
National Cancer Institute, and for guidelines and for, because as we were talking about, it's not always clear what the guidelines are and who they're for and what our decisions should be. So that's all personal, individual choice. I'm going to put all of the links in the show notes for people to be able to do a little more research on their own to find out what they might choose to do for cancer screenings. Mary, this has been very helpful. Thank you so much.
Well, thank you. It's really always fun talking to you. Thank you, Wendy, for all the good work that you're doing.
Oh, my pleasure. My pleasure. I also want to remind people that if you want to be part of Boomer Banter, you can sign up to be on the newsletter distribution list where you will find out all about what's going on. And I also share really relevant articles about things that relate to us in the stage of our life. You can go to heyboomer.biz, B-I-Z, and click on Connect with Us. I also wanted to mention that we have an Alzheimer's walk team, Walk to End Alzheimer's, and our team is walking on October the 5th. We've set a goal of raising $5,000 and we're about 40% there. If Alzheimer's has affected you or someone you know, or if you want to support the organization, we would greatly appreciate you supporting our team and the wonderful work that the Alzheimer's Association is doing. You can do that by going to act.alz.org/go/heyboomer or join our team. Join us and walk. So who's coming next week? Next week, we're going to meet Deborah Edgar. And Deborah has a long tale of loss and family dysfunction that created years of insecurity and self-doubt. But in 2022, she suffered an unbelievable and almost unbearable loss. Her journey of recovery is now part of a small yet helpful book titled Good Grief. Some of it is directed at the person who is grieving, and some of it is directed at society in general. How we deal with grief individually and as part of the larger community can help with the healing process. So I hope you will join us for that next Monday and point other people to the show. If you are not able to listen live, I hope you will enjoy the podcast and rate and review us. Mary, thank you so much.
Well, thank you, Wendy.
Each episode of Boomer Banter is an invitation to listen, learn, and apply the wisdom gained to your own life. We are a supportive community, so join us as we age well together. Boomer Banter is produced by me, Wendy Green, and the music comes from Purple Planet Music. Thanks so much.